Hi, everyone. I am Terry McGovern. I'm the Senior Associate Dean for Academic and Student Affairs at CUNY School of Public Health. And I have the great honor of welcoming you to our first speaker in our new Sexual and Reproductive Justice Speaker Series. For those of you who haven't been following CUNY School of Public Health closely, we've been establishing a Sexual and Reproductive Justice Hub with lots of exciting research, convenings, partnerships, advocacy. So we are really excited about the work that our students and faculty are doing. We're really excited about working with all of you, and we're going to try to bring some extraordinary colleagues into this webinar to talk to you all. And I'm thrilled to introduce our first speaker, who I have the great pleasure of getting to work with very closely, and that is Dr. Sabrina Das, who is the 2024-2025 Harkness Fellow with the CUNY SPH SRJ Hub. And this important partnership is supported by the Commonwealth Fund. She is studying the abortion landscape, harm reduction, and the healthcare equity work around abortion care in New York. She is a consultant obstetrician and gynecologist at Queen Charlotte's and Chelsea Hospital in London, and an honorary senior clinical lecturer at Imperial College. She's also a national maternity improvement advisor at NHS England, and a member of the board of trustees for Doctors Without Borders UK. After graduating with honors from the Glasgow Medical School in 2004, Sabrina Dr. Das has worked in Scotland, South Africa, and London, completing specialty training in Northeast London. She has advanced training in high-risk obstetrics, abortion care, maternal medicine, and medical education. As a consultant, she's led local, regional, and national teams in quality improvement, recently completing a senior leaders apprenticeship with Henley Business School. I can tell you that she believes passionately in service to vulnerable communities and the single most disenfranchised group in the world, women and girls, which led her to Doctors Without Borders, with whom she's worked in war-torn Yemen in 2021 during the COVID pandemic. Dr. Das is really a strong human rights advocate and just a joy to work with. So over to you, Dr. Das.
Thank you so much for that, Terry. I'm so glad to be here and to share in this conversation with all of you. So I am going to hopefully share my slides with no issues. Okay. So I'm hoping I'm going to go into slideshow mode. That should look right to you guys. So I'd like for this to be primarily a conversation, and there's so many experts in the room today, including Terry. So that's great for me, because if you ask any questions that I can't answer, I'm sure somebody here will be able to pitch in. I encourage you to put any thoughts or comments or questions in the Q&A section, and we will have at least 30 minutes at the end to discuss them together. So with so much expertise here in reproductive justice at CUNY School of Public Health, I thought that the most interesting thing that I can contribute today are some stories from the field, working as an OBGYN in multiple different settings. But I'll start by sharing my personal story. So I ask that you see me as a doctor, but I'm also a mother. I'm a traveler and an adventurer. I'm a migrant. I'm a child of migrants. In London, I am an OBGYN specializing in high-risk pregnancy, complex intrapartum care, and abortion care. I was born in Singapore into a multi-ethnic family. Here you can see me with my paternal grandmother. My parents were from Malaysia. Both were the first in their generation to go to university. And my grandmother, this is my dad's mother, she was a child bride. She had her first baby when she was about 15 to 17 years old. Nobody can actually be sure. She couldn't read or write. And it's quite amazing because in one generation, my dad actually went to university and he worked as a professor in biochemistry. He was number 10 out of 12 children that my grandmother had. Now, my mother, on the other hand, she was an only child, but she was adopted. Her biological parents were too poor to keep her, and so my mother was given up when she was 2. She didn't tell me about her adoption story until I was an adult because it was a source of shame for her. And she suffered a lot of cruelty as a child, not from her adoptive parents who adored her, but from her extended family and from others around. When I was 10, my mom was pregnant with my youngest sister. It was planned. Like I said, my dad was a biochemistry professor and he was coming to the US for a 1-year sabbatical, and we were all coming with him. We were really excited. My parents thought it'd be a really good idea to utilize the birthright citizenship and got pregnant before we left so that we could have an American citizen in the family. So that was my baby sister, who you can see here in the photograph on the left. After one of the ultrasound scans, I came home and found my mom crying alone in her bedroom. And because I was the good eldest daughter, I was very concerned. I asked her what was wrong. And she told me, the baby is another girl, and I didn't want to bring another girl into this world because women suffer. I was confused at the time because this story of suffering wasn't my story. But I very soon understood what she meant. You see, my father died of cancer about 3 years after this photo was taken. And it was with the support and care provided by many, many women, aunts, teachers, cousins, friends, that my mother, my sisters, and I survived and eventually thrived. You can see on the right in 2011, a few months after my youngest daughter was born, another household of women. So there I am with my 2 daughters and my 2 grown-up sisters. I became an OBGYN, an obstetrician and gynecologist, because I wanted to lessen the suffering of women. I wanted to help women and girls like my mother, like my mother's mother, like my father's mother, my sisters. I wanted to help women like myself and women like my daughters. I'm going to share some of the stories now from my time working in various settings, and I wanted to add a disclaimer that I share these stories not to criticize any healthcare delivery system, any culture, or any country. My colleagues and patients are resilient and skillful and amazing, quite frankly. But I want to paint a picture for all of you to reflect upon, because with each story, I want to illustrate how far we have to go in order to accomplish this aspiration of bodily autonomy on a global perspective for women and girls. I want to explain what my mother meant when she said that women suffer. So I spent a year working in Cape Town, South Africa in 2012, 2013. Mowbray Maternity Hospital is what you call a secondary referral hospital. So in the public healthcare system in South Africa, all pregnant women by default get seen at their local community midwifery unit, and they get referred after their first visit to the secondary tier hospital if there are any so-called risk factors. So if they've had a previous cesarean, if they have high blood pressure, anything like that. Sometimes they get referred and transferred only in labor. When the labor is too slow, if the baby is breech, that means that the baby's bum is presenting rather than its head. If a woman is unwell with fever, convulsions, anything like that. Mowbray manages 10,000 births a year. So I learned a lot of things when I was there. I learned lots of technical skills, how to use an ultrasound machine, how to do 10 cesareans in one shift. And the hospital also had a policy around how women were not allowed to leave the hospital after having their baby unless they had a form of contraception. So this could be a packet of pills in their bag, or it could be an injection they'd received whilst they were on the ward, or they could have had a coil inserted shortly after birth. We even did sterilizations after vaginal birth with a little tiny 2-centimeter incision underneath their umbilicus, so just underneath the belly button. And all this was kind of amazing to me. It still is amazing now, because in the UK, and I'm sure a lot of my US-based colleagues will also empathize with this, it is nearly impossible to enact this kind of policy of postnatal contraception, because contraception and postnatal care comes from a different budget. So it comes from the primary care budget, in the UK it does anyways, and the hospital, which is secondary care, refuses to pay for it. Oh, sorry. So this, so I was really impressed by all of this whole provision of postnatal contraception. But underlying this very useful public health policy was something else. And I think you can understand that there's lots of nuance in this, and two things, conflicting things, can be true at the same time. Because although it's a great public health policy, it's also a reflection on a very deep judgment around the impoverished Black women, around a third of whom were HIV positive, that were accessing the public healthcare system. And I have many, many stories to share, but one was about an HIV positive woman who was having her third cesarean. So once you had 3 cesareans or 2 cesareans and you're having a third, the doctors really pressure you to have a sterilization. And I think this is certainly true in the UK, and it's probably true here in the US as well. The issue is with this woman was that she'd only had 1 living child. So in a context like South Africa, you've got a lot of infant mortality. And this woman had 2 babies born by cesarean, but only 1 was still alive. And the baby inside of her had also passed away. So she was having a cesarean for a dead baby, and she was also having a sterilization at the same time. And I felt so sad that she was compelled to have the sterilization, that I told her while she was on the operating table, when we do our checklist, we make sure that we've got we're all on the same page for what operation we're doing. And I said to her, you don't need to do this. If you want to have another baby, we can support you through another pregnancy. It's our job to support you into having another baby if that's what you want. And the other staff in the operating room just thought I was crazy. They were all like, Sabrina, what are you doing? If you talk her out of this sterilization, she's just going to come back next year, and we're busy enough as it is. And she told me, doctor, I want this. So she looked into my eyes and she said, I want this. So I felt assured that this was indeed her choice, but I still felt sad that she had to make this choice. And a lot of you as reproductive justice scholars will recognize this wider issue around bodily autonomy and reproductive choice, and how social inequality, economic apartheid, and history deeply roots our perceptions and beliefs around who deserves to be a mother. So, Yemen. In 2021, I served in Yemen on mission with Médecins Sans Frontieres, which was a lifelong professional dream of mine. And one night I was woken from my sleep and called down to the ER. It's a code black, was what I heard on the phone. And if you look at the hospital here, the top floor was where we all stayed, and we lived on the top floor, the international staff, and the rest of it was all this, what we call the mother and child hospitals. So we had pediatric wards, we had maternity wards, and we had outpatient clinics as well. Code black. ER, ground floor was the ER. And I didn't know what this actually meant, but I soon worked it out. I went downstairs. A mother in her 30s, she was in her late 30s. She had 8 children at home. She was in her 9th pregnancy, and she had arrived, and she was already dead. And she still had her baby's head between her legs, suffering a complication known as a shoulder dystocia. And I did the only thing I could do to restore dignity to this poor woman and her baby. and I delivered the dead baby with a lot of difficulty so the family could have a respectful burial. This woman had one antenatal visit in her pregnancy towards the end of her pregnancy, and the doctor told her that she was low risk and she was safe to have her baby at home as per tradition with a midwife. You can see this map here. Let's see if I can get the pointer to work. Hopefully that works. So that little white dot here is where she lived. That's her village. And this blue line is the road to the hospital. Her nearest hospital was here, called Ad-Dimna. And a little bit beyond that was where I was working, this little red marker here. So it's a 2-hour journey between her village here along unpaved roads to Ad-Dimna. And along here, she has to actually cross the front line where the fighting is. So you can understand her reluctance to have her baby in a hospital. So she decided to have her baby at home. She was in labor at night, and her labor arrested in the middle of the night in second stage, which means that she was fully dilated. She was pushing for a few hours. And to help the baby come, to make her contractions stronger, the midwife gave her a dose of oxytocin, an injection. I think in the US you call this Pitocin. It's the same thing. So it makes your contraction stronger. And the baby's head was born, and the woman started bleeding from what was very likely to be a ruptured uterus that occurred sometime after the oxytocin was administered. Now, in the low-income setting, we talk about the 3 delays leading to maternal death. The first delay is in the delay to seek care by the patient, and this can be for lots of different reasons. It can be because they don't trust the hospital. It can be like this woman I already explained. In order for her to get to the hospital, she has to cross the front line. It was in the middle of the night. It wasn't safe for her to travel. So she had the oxytocin instead of seeking care when her labor arrested. The second delay is the delay in getting to the hospital once the patient decides she needs to go. And this woman didn't have any transport. She had to call her husband's brother, who lived in a different village, and had to bring the car and then travel along completely inadequate roads to get to this hospital at Dimna. The third delay is the delay in care once she arrives in the hospital. So she arrived in the hospital. She was still alive. They refused to treat her. They told her husband that she was too sick for them to treat her and that she needed to go to a hospital with an intensive care. More than likely, they knew that there was a high chance that she would die on the operating table, and they didn't want to deal with a death in their hospital. And so they decided not to even try to save her life. Or maybe they didn't have a surgeon, because it was in the middle of the night after all. Or maybe they didn't have a surgeon who had the necessary skills, or one who was comfortable with performing the procedure. And she died 10 minutes before she arrived at my hospital. So her death resulted directly or indirectly from the fact that Yemen had been embroiled in a civil war since about 2016. So these are the things that we have to deal with and contend with when we're thinking about access to reproductive care on a global perspective. And I'm going to go back to linking bodily autonomy with maternal death in a minute, but I want to lift your spirits a little bit, so I'll tell you a slightly happier story. Back to my home in the UK. This is Kadra. She was one of my patients in 2022, and I met her one morning when I was rostered to do planned cesareans. I went to see her during my pre-op ward round, and she told me that she had twins, but that she wanted to have another scan because her first baby was breech. And if her first baby had turned, she wanted to try to have a vaginal birth. Her baby hadn't turned. Her baby was still breech. In fact, both of her babies were breech. And I asked her if anyone had offered her a vaginal twin birth. There are additional considerations, and there's an increased chance of needing a cesarean during labor or during birth. But she'd already had 3 babies vaginally. not very long ago. In fact, they were all, her 3 children were under the age of 5. So really, objectively, from an evidence-based point of view, she should be able to have a straightforward vaginal birth. And she told me that all the doctors she had spoken to told her that it was not allowed and that it was very dangerous and that both her babies might die if she chose vaginal birth. So really here in the UK, the barrier to her bodily autonomy being respected, her choice not to have a cesarean birth, was nothing to do with financial resources or the state of the roads. She was a Black Somali immigrant woman. She could speak and understand English perfectly, and her rationale for wanting vaginal birth was completely reasonable. She understood the risks that had been explained to her many, many different times by different people. And she told me, I'm going to have 5 children under 5. We don't have any family here in London. And if I need a cesarean, I'll have it. But if I can avoid it, I would rather not. And most importantly, she told me, I just think my body can do it. And as well, Western healthcare models continue to prioritize the safety and comfort levels of doctors and hospitals over the needs of women and pregnant women, we will continue to see a devaluing of essential skills such as vaginal breech birth, other complex vaginal births such as twin birth and later abortion skills. Because why should I bother to upskill myself if a surgeon's knife on a woman's abdomen is so much easier for me? Not easier for the woman, but certainly easier for me. Anyway, to finish the story, I gave her a sweep, which is a vaginal examination, and it helps to release your natural labor hormones, and it sometimes kickstarts labor. And for her, it worked. She was already 3 centimeters dilated when I gave her the sweep, which is a good sign. She went home that morning and she came back that night in labor. And one of the midwives that I had trained in vaginal breech birth delivered both her babies, and she named one after me, which is one of my proudest moments. And I didn't even have to deliver the babies myself. All I did was trust the woman. So I think it's fair to say that we can use global maternal mortality rates as a surrogate measure for bodily autonomy. And it's not perfect, and it really is just the tip of the iceberg. And measuring global MMRs, maternal mortality ratios, is another lecture in itself. But I wanted to show this slide just to demonstrate, you can see very, very clearly that the continent of Africa is where most women die in pregnancy or as a result of pregnancy. Sub-Saharan Africa alone accounted for approximately 70% of global maternal deaths in 2020, followed by Central and Southern Asia, which accounted for about 17%. So a 15-year-old girl, and my daughter is now 16, so nearly the same age. If you consider a 15-year-old girl in Sub-Saharan Africa in 2020, she has a 1 in 40 lifetime risk of dying in pregnancy. And this is compared to 1 in 16,000 in Australia and New Zealand, the light blue patches. This concept of lifetime risk of dying, just to help you visualize it, right? My daughter is 16. So, and I know a class of 40 is a lot, but I think New York public schools are 32 max. Imagine a class of 40 girls, teenagers, sophomore students, and imagine it's a girls' school. I went to a girls' school when I was that age. 15 sophomore students. One of those girls will die in a pregnancy-related cause in her life. That's what we mean by a lifetime risk of maternal death. You have 0 bodily autonomy when you are dead or dying. And this is why the determination of the Trump administration to withhold foreign aid and life-saving programs such as PEPFAR, and I know they've reinstated this for now temporarily, and to reinstate the global gag rule is absolutely 100% an attack on bodily autonomy for women, girls, and anyone who can become pregnant. So this line graph on the left shows a steady reduction in global MMR in the first 15 years of the UN Millennium Development Goals program. So there you can see 2001 to 2005, 2006 to 2010, 2011 to 2015, and then you just see a flat line after that, 2016 to 2020, and we only have data reported up to 2020. But between 2020 and 2024, we haven't really made any more progress. We flatlined. And And so we're really not making any more progress towards sustainable development goal number 5, which is around gender equality. So now is really not the time to cut foreign aid programs, and it's really not the time to withdraw from the World Health Organization. If you think that a lifetime risk of dying from pregnancy-related causes of 1 in 40 is too high, then this is not the time to cut foreign aid programs. Now, I had to make a special mention of this dark blue country here, which is one of the countries where maternal death rates have actually increased rather than decreased in recent times. And this is Afghanistan. So last month, on the 1st of December, the Taliban ruled that women are no longer allowed to graduate from medical education programs, and this closes their last loophole for women to engage in higher education. This means that medical students, nurses, and midwives will not graduate, and we will lose an entire generation of healthcare workforce. This is in a country where it's also against the law for women to be treated by a male healthcare worker without a male escort. And I promise you this is not fake news, because we've had first-hand confirmatory accounts from our Afghan MSF staff that this is being enacted. I'm now going to attempt to link bodily autonomy with human rights, and I'm not a human rights expert. If you have any questions on human rights, I'm sure Terry will be able to answer them in the Q&A later. But I just wanted to make a link between human rights and maternal death, because again, you can see here that the continent of Africa is being highlighted in this map, which is published by the Global Rights Project, and they publish annually a scorecard of human rights according to how each country scores. So you can see, I mean, we don't have exactly correlating maps, they're not exactly the same, but there's some relationship between the lack of human rights and the previous map displaying maternal death rates. And the world has recently experienced this polycrisis of the 5 Cs. We're still recovering from COVID. The healthcare workforce is still recovering from COVID. We're experiencing more conflict than we have in many years. Corruption, climate emergency, and the cost of living. It feels like we have a broken international system of global governance and an infiltration of spaces with anti-rights rhetoric. And the strategy for anti-rights groups is to pick an issue, such as transgender rights, migrant rights, the asylum system, and erode those human rights, knowing that any erosion of human rights will threaten all the other human rights. And this is not how human rights works. It's not a buffet. Having a rights-based approach demands that we maintain and build our coalition of support. And this is why, through my research this year around abortion access, I found all sorts of organizations contributing to increasing abortion access that form this wide coalition. So I'll give you some examples of what I mean. STAR is a community-based organization in Louisiana providing support to victims of rape. And their advocacy arm has been getting survivors of rape who trust them because they provide them with care to give testimony to the state legislature in support of abortion access. So it's about building these coalitions where you wouldn't naturally draw a natural link. Another example is If, When, How. This is a reproductive rights legal organization that's best known for its repro-legal helpline and defense fund. And although they started their helpline to help abortion seekers navigate this landscape post-Dobbs, they found an increase in queries around child welfare and family policing. And so they have responded to that need by providing research and materials around that area as well. So having a wider view of issues and having a degree of flexibility and responsiveness that goes beyond staying in just the abortion lane is really important. So what can we do about this? On the 5th of November 2024, many of you woke up like I did in shock, horror, and disbelief. American voters, some of them your friends, some of them your parents, had elected a convicted felon, liar, and rapist. Like me, you felt that you were walking streets that felt less safe than they were the day before. You knew that your work would be harder, that your will and your drive would be tested, but you're here now. And the fact that you are here really brings me hope as we gather in this community, because my mother was right. Women do suffer. But I've also learned that women care and build and restore and unite. I've had the privilege to learn from Indigenous healthcare leadership and scholarship since I arrived in the US as a Harkness Fellow, because two of the other fellows in my program are Native Indigenous leaders from Canada and New Zealand, respectively. And so I've taken a lot of knowledge from that. What is good for the native is good for everybody, said Tecumseh, who is a Shawnee warrior and chief, and he lived in the early 1800s. So the point I'm trying to make is what is good for us is good for the world. And I really want for us to feel interconnected, even though it can sometimes feel really hopeless and lonely. In caring for someone in Yemen or Afghanistan or South Africa or New York or Louisiana, if we are using and living and breathing that rights-based framework in our work, we will be serving those afar as well, because we're a global community that learns from each other and affects one another. So identify yourself as working in one of these catalysts for change, or maybe in more than one. In my time as a Harkness Fellow, I have sought out examples of all these catalysts working to improve abortion access post-Dobbs, as I know this work can also be used and replicated in the global setting. So I'll give you some examples to lift your spirits up. Social norms. Lift Louisiana is a legal advocacy group with a deep canvassing arm where they use door-to-door canvassing as a strategy to shift public opinion around abortion. Under the category opposition, I can think of Indigenous Women Rising, which is an abortion access fund for Native women nationally. They also fund midwifery care or doulas for Native pregnant people, as you know, these services often require out-of-pocket payments. They also fund expenses relating to enabling the ritual burial of remains after a spontaneous or an induced abortion on the tribal lands. Caring for your community is a real and effective method of opposition and resistance. Under education, there are so many examples. Education is the cornerstone to autonomy. Heart Women and Girls is a Muslim reproductive justice organization that's all about creating resources and culturally safe educational materials so Muslims can exercise self-determination in their reproductive lives. It combats stereotypes, misconceptions around Islam and abortion in a way that connects with Muslims. For example, I recently learned the concept of ijtihad, which is the Arabic concept of self-determination. And it's one of the concepts used by Muslim feminists to assert that abortion is halal, or abortion is allowed within the Muslim faith. Under law and policy, passing shield laws have been so critical in protecting providers, such as aid access and the MAP after the Dobbs ruling, who bravely act as medical abortion providers to abortion seekers in banned states in spite of all the personal risk. I've learned that we can reduce but not eliminate the suffering of women and pregnant people. And it is relentless work, but nevertheless joyful work. And so I will leave you and finish with words from Kamala Harris's concessional speech, which really continues to resonate with me. Don't ever stop trying to make the world a better place. You have power. This is not a time to throw up our hands. This is the time to roll up our sleeves, because only when it is dark enough can you see the stars. So I'd be happy to take anything from the Q&A. I think,
Can you see the questions, Sabrina? There's one from Lynn. Are the contraceptive services provided with informed consent?
So Lynn, I'm assuming you're talking about in South Africa, right? You know, I think yes and no.
Yes.
Yes, in South Africa. Yes, you know, in my experience working with in South Africa and in many other contexts, women really want to use contraception. They really, really do. So it is with informed consent in that we provide it, we consent it. It's not forced in any way, But I say it's not forced, but you can't leave the hospital unless you've accepted some method. So even if you've just accepted some pills and you put it in your bag, they don't actually allow you to leave the hospital. And I'll share another story. And this is we had a 17-year-old girl, and she suffered a severe, massive obstetric hemorrhage. So during her birth, she suffered a lot of bleeding, and because there's no blood transfusion service in the hospital, there's like a lower threshold to using hysterectomy, which the doctors justify as a life-saving operation, which it is. It's a life-saving operation. So this 17-year-old girl, in her first pregnancy, had a hysterectomy, and she was then subjected to subsequent trauma because the security staff wouldn't let her leave the hospital because she didn't have any evidence of having accepted a form of contraception. So, are the services provided informed consent? In theory, yes, but in practice, I think underlying that is what I'm talking about, that deeply rooted prejudice and I guess just cruelty in the way you think you can speak to Black people in South Africa and in many other countries. So, yeah.
Thank you. I think, Sabrina, Dr. Das, I have other questions, but I did want to note what you showed, which was we were making progress, right? And then just this complete obsession with restricting the bodily autonomy right, has really actually interfered with progress in reducing unwanted pregnancy, right? And could you just say a bit more about that, between the global gag rules, all of these restrictive laws, all of it really is hurting progress, no?
I absolutely agree, Terry. And I could just maybe just talk about the global gag rule, because that's a specific thing and not everybody might know about it. So it's just basically this law that US money, that federal dollars, that the money that you pay into the federal tax system shouldn't be allowed to fund abortion anywhere. So whether it's in the US or whether it's in, Congo or whether it's in Kenya, it's our federal tax dollars shouldn't be used to fund abortion anywhere. So this affects lots of things, because not only does it impede on a woman's choice to have an abortion or not have an abortion in a country where it may be there isn't any legal obstruction. It also affects the NGOs and other organizations' ability to provide maternal care, because abortion services don't just sit there alone in the clinic. They're also they also provide contraception. That same space provides contraception. So if you take away the funding for the abortions, you're also taking away the funding for the contraception, and a lot of the same staff will be participating in maternity care, antenatal care. So you're also essentially shutting down services that provide maternal care. So just so when we link it to maternal death, it's not only the direct maternal death that you see, because lots of women are going to have pregnancies. And when we talk about that lifetime risk of pregnancy, if you have 12 pregnancies, like my grandmother did, she had more than 12 pregnancies, actually. She had a few stillbirths as well along the way. If you have 16 pregnancies, the chances of something going wrong is higher. And that's why that lifetime risk of maternal death, it's 1 in 10 in Afghanistan.
Thank you. And I also, I was part of research on the most recent Trump administration global gag rule, the last one, Nepal, Madagascar, Kenya. And first of all, it was a broader gag rule. It applied to all global health, not just sexual and reproductive health funding. In addition, it applied to sub-grantees. And what we saw really is what you described. You have fragile health systems. And the global gag rule, the US exporting its view, or at least its leadership's view, really tears countries apart, countries that are under-resourced. So in addition, it's the same thing that we're seeing here in the States at the moment, trying to create all kinds of divisions between providers, right? Where they can get their partners in trouble if they tell this or they tell that. We're seeing this so much in the banned states here in the US, criminalization. It seems to me there's the objective evidence of it tearing, destroying access to care, but also this kind of menacing, chilling way that it rips partners apart. I think is a strategy that we're seeing used more and more,
Yeah, absolutely. And you see this kind of like self-censorship or people
Mhm.
overcorrect, people overcorrect.
Yes,
Because
yes.
they're afraid. They're afraid their funding's going to be revoked. They're afraid their livelihood's going to be on the line.
Yep. So I have a bunch more questions. There's one that's kind of a big one, but I'll leave that for now. Have you experienced both safe and unsafe abortion as an OBGYN in the different countries where you've worked? Would you be willing to share your observations?
Yes, I can share. So unsafe abortion is one of the leading causes of maternal death globally. Um, it's I have to say, for me personally, I haven't worked in a context where I've seen many women coming in with complications of unsafe abortion, but I have, worked with colleagues that have seen this happening. In terms of safe abortion, I mean, in Yemen, it's very difficult, right? Because it's just not allowed, right? It's just illegal and it's not allowed, and you're not allowed to publicize it. You're not allowed to say that you're providing abortion, because you're then threatening your ability to have operations in a country like Yemen, because humanitarian healthcare organizations have that really fragile relationship with the government that allows us to practice there. So again, in Afghanistan with the Taliban. So I'm not going to go into any specifics, but I can tell you that in general, MSF does provide abortion, and we do try and, well, we know how to provide safe abortion. And our line is that we offer safe abortion care alongside all our services. But in reality, it's very, very difficult. It's very difficult because all these barriers that women face before they come in front of an MSF provider that's able to do it in that restrictive context. But I mean, can I just say, in Yemen, if you have a woman who's pregnant and she's not married, she runs a real risk of an honor killing, being killed, being murdered by one of the male members of her family, because it's just so stigmatized isn't even the right word. It's just horrific, in terms of stigma and the rights of women that are being, as you pointed out, that are being eroded even more in certain regimes, such as in Afghanistan. So yes, we can provide safe abortion. It's very, very simple to provide safe abortion. Medication abortion is very, very safe. Even in the second trimester, when you combine it with availability of hospital and clinic-based support to complete the abortions should anything happen or anything go wrong. But in terms of the actual provision, it's not the medical stuff that makes it unsafe. It's everything else around it. It's the barriers and the society and the stigma. Oh, you were muted, Terry. Sorry.
I got excited, forgot to unmute. I wanted to follow up on something you said before I go to the next question. You said humanitarian organizations are in a very precarious situation when they go into countries. So right there, now I'm going to be my lawyer self. I love working with providers because we see things from different angles, but it's all important. So most countries, 2/3 of countries in the world have what we call plural legal systems, which means there's often customary or religious law. And often, even if they've ratified international human rights instruments or even passed civil laws that outlaw child marriage, other things, they find ways to actually have exceptions. They either don't domesticate or they say plural, religious law applies in family settings. So usually, many times humanitarian actors are trying to provide these services in a country that is not abiding by international law, is applying, their local religious or customary law. So that's where we get into a lot of trouble around third-party consent, around unmarried women. So just to point that out, it's really an important part of this equation. But to go back to the questions, here's one. I'm a college student in the US on a pre-med track. How can those of us without medical or law degrees help others realize bodily autonomy in times when abortion rights and birth control are under threat? What do you think is the most important thing students can do to take action?
Students can do so much, I think. Terry, I'm sure you'll have ideas yourself on what students can do. Students, students can do so much. So medical students can look up an organization called Global Doctors for Choice, and you can join them. And they've got advocacy programs, they also do work to improve medical curriculum in certain medical schools in terms of what sort of exposure you're having to abortion curriculum. So if you as a student, you're seeing, you're not getting something. So I think with abortion, it's like what we don't talk about, right? So if you see an omission in your curriculum, then yeah, I mean, you can advocate, you can organize as students. You have so much power as a student body to ask your university to provide something that you do not have. And my colleague, who may be on this call, Meredith Manzi, is where she's leading a study at the moment, looking at how student advocates had advocated for medication abortion to be provided by college campus clinics on their college campuses, which is a really interesting, super interesting story. And when it gets published, hopefully will provide a kind of best practice and guide for other student organizers or other states that want to do the same. So think of what you're not getting in terms of your reproductive rights, and students have a really loud voice, so go and advocate for it. Terry, do you have any other suggestions for how students can? No, you're muted again.
No, thank you. I do like to always point out that when they extended patents in the mid-90s, right, when the HIV treatment became available, it was really a massive global student movement that demanded that there be flexibilities for life-saving treatments, and a lot of what we saw unfold was absolutely due to student activism. I think students are critical, students are the future. And I think what you said about curriculum is obviously something we're really thinking about and trying to do here, which is teach maternal child health a little bit differently. Of course, all students need to understand all the epidemiology, research methods, et cetera, but they also need to understand the political issues that are the inequities, the human rights abuses. They're just as important as the other parts of the education. I think more and more people are understanding that. And I think our students are just students are the greatest resource in the struggle against this kind of absolute intrusion on bodily autonomy. Let me read you another question. Thank you for this great presentation. Are you aware of any radio media campaigns to shift social norms regarding bodily autonomy, especially in areas of the world that are experiencing high maternal mortality? I've heard of this approach used before to tell stories and shift narratives with other human rights issues, improve relationships between different groups. I'm curious if you're aware of whether this has been explored as much with this issue.
So is the question around like media campaigns in other countries to link maternal death with abortion rights and bodily autonomy? Is that the question?
Yes, I think so. Yep.
Let me think. So the answer is yes. There, because I mean, to me and to people on this call, it's an obvious correlation, isn't it? And in lots of contexts, it is about life and death. I mean, and speaking to people here in the South, maybe you don't feel this in New York, but people in the South feel this. They feel that abortion access is a question of life and death. So the answer is yes. Off the top of my head, and I don't pretend to be an expert on this issue. And also the other thing I found is that with these media it's all, they're all on social media, and you find out about one by following another. So a lot of it is through word of mouth, or once you follow one, like Instagram starts like giving you all sorts of suggestions. So for example, when I looked into support for Muslim women, I came across an organization called the Adiya Collective, and they have, so it's ADIYAH. So if you search them on Instagram, they've got a lot of resources aimed at the global setting of globally at Muslim women. They've even got like a page with abortion doulas, some of whom are situated in the Congo, or will do kind of video calling in Arabic. So yeah, the answer is yes. And I guess my suggestion for you is just to go out and look for them and just find them.
Or create them if you're right.
If
Thank
see there's
you.
a need, yeah, a lack.
So another question, we have a few more. Was it in Yemen where the pregnant woman was left to die? I wanted to know if obstetric violence is set like that in the penal code, or is there in any way that doctors are penalized when these things happen? We have seen how these measures impact directly on the unwillingness to even treat the pregnant person when they're already too sick, so that you don't end up penalized.
So I'm not an expert on the law in Yemen, and Terry, you might be able to add about that. But what I can tell you what I observed. So the answer is no. The doctors that didn't provide this woman with care, nothing would have happened to them at all. For women that died in my hospital, and we didn't have very many, but we had a few, all the governance is all around, it's all internal. So we as MSF, we look at all our, we try, and I tried when I was there, very, very hard to look at all our incidents and to make sure that, we're doing everything we can and that we're improving and all of these things. So all of the governance is all internal. There wasn't any external kind of scrutiny on anything that was happening in our hospital, or any of the any scrutiny would be in that kind of way that that the Houthis were wanting to scrutinize. So if they weren't happy with you doing a certain thing, like they weren't happy with you talking to women about contraception without their husbands there, for example, that's the kind of scrutiny that we get. And what we also get is you get a lot of kind of, I don't know what you want to call it, like people taking things into their own hands. So the shocking thing about working in Yemen is that like people just carry guns everywhere. And so if somebody dies in your hospital, there is a very serious risk of the male members of that person's family coming in and just shooting your hospital. So
Wow.
that happens. And so it's so different. It's a different world. The systems of governance do not exist. And so I'm not in any way surprised that if a woman dies in a Afghan hospital, nobody is going to bat an eyelid and look and seek to hold anybody to account. Terry, I don't know if you have anything to comment about the penal system.
No, just there's the same. So we know that, many of the banned states have the fewest laws, protections, policies in place for maternal child health care, have the worst foster care systems. And there's this incredible attention on punishing doctors who might treat a dying person who may have tried to give themselves an abortion or end a pregnancy, right? There's this utter devotion to this, and you hardly hear about efforts to hold physicians accountable in these other contexts, right? So it feels to me like it's the same, which lives do you care about? So I think, these contradictions that the questions are illuminating, I think, are ever present and really, really important. I think in even shifting people's understanding. And it's, of course, something that sexual and reproductive justice as a framework has always done, which is why it's so important and so much of a strong framework to get at these issues because they're all connected. So another question is, IUD insertion seems to be happening post-birth in low-income populations in the US, but not until 6 weeks postpartum for higher socioeconomic status women. It's an easier and less painful right away. It's easier and less painful right away, but is it riskier?
So there's a higher risk of expulsion if you put it in straight away. So, I mean, I can't remember the exact guidelines, but it's something like you can insert it like 2 to 5 days after, and that's fine. I mean, some of these guidelines are just made up anyway. So you kind of, sometimes you just use your own common sense. And if the woman isn't going to come back, or it's really hard for her to come back and she needs it to be put in now, then you just weigh it all up and you put in the IUD for her. In terms of pain and discomfort levels, I mean, if you've just had a baby, maybe it might be less painful. If you're having a cesarean, you can put it in at the same time as the cesarean, and then woman doesn't have to feel anything. But certainly, depending on how the cervix is, how dilated it is at the time when you're putting it in at cesarean, there's a higher expulsion rate. So your point being about how one group of women is being treated a certain way and another group of women is being treated a certain way. I mean, you know what? Exactly. It's not scientific, is it? It's not. Why are we offering certain package of care to low-income women and different package of care to high-income women? Doesn't.
Right.
And really, like, if you're high income and you want to have it in at day 2, why shouldn't you have? You should be able to have that rather than having to wait 6 weeks. But it's just we're not centering the woman. In this, we're centering what's convenient for the hospital, what's convenient for the doctor, what's convenient for the clinic. I mean, I learned so much when I was in South Africa. I mean, that example I gave you about the sterilization after vaginal birth. I mean, we don't do that in a high-income setting. And you can do it. You can do it really easily with a spinal anesthetic. And the incision is this big, but we don't do it in high-income settings because, I don't know why, but we just don't do that. We just don't do it.
So I'm just, we have a colleague from Cameroon, and the question is, how do we continue to move beyond abortion as healthcare and towards the concept of bodily autonomy in reproductive care policy and advocacy? You know, many abortions are not necessarily a life-saving procedure, but it's a matter of choice for the pregnant individual. I think many people find abortion is healthcare is more palatable of a concept for some groups culturally, politically, but it doesn't quite get us to a full understanding of bodily autonomy. Is this even possible? So that's a question about, right? That's a big question about strategy, how we talk, right?
Discuss. Yeah, I agree, Terry. I think it is about strategy and how we talk. And sometimes you use different words or different strategy depending on what the moment is. And, I think this is some conversations that I have with people as well about like purity of your politics or purity.
Right, sure.
And, that's why I think it's about like employing different strategies and different ways of framing depending on what your community is ready for.
Yep.
Right. That's why, for example, I was talking about Lift Louisiana. They're a reproductive legal organization in Louisiana, and that's why they do their deep canvassing, because they go door knocking and they speak to families and people in Louisiana in their communities who might be, religious or just because of their societal values, they're anti-abortion. And this way they keep the finger on the pulse because they want to see, what messaging resonates with the community, so that then they can frame their strategy. And what they found, and that's why they've collaborated with STAR, the sexual trauma organization, is because, and STAR says, look, it's so important for us because it is very, framing it as we need to make abortion available for survivors of rape. That's something that everybody can get behind. And so to be too much along the line of purity and, that's not enough. And, if we can't get bodily autonomy and choice, then we're not going to do the other thing. I mean, that's not necessarily helpful. So in terms of strategy, I think, it just depends on your local context. Terry, what do you think from your years of experience?
Yeah, well, I mean, I think, I think this is a really interesting question and a complicated conversation. On the one hand, we want to say abortion is healthcare because it should be available and routine and it should be just a part of healthcare. On the other hand, what we have in this country now is an administration that has a lot of members in it that are guilty of gender-based violence or sexual assault. We have a whole bunch of executive orders, attacking trans people, attacking LGBTQI. So attacking, even what our children can read and learn. So when you see this level of an onslaught from all these different directions, that's when you have to kind of come back into the bodily autonomy. What are we talking about here? People's right to human dignity, to make choices about their bodies, their lives. So, you kind of have to use it all because abortion should be healthcare. But obviously, to achieve human rights, or the human right to health, you shouldn't be attacking any of these things, right? So I think we have to kind of, never lose sight of those, kind of sometimes conflicting concepts, but and understand that strategy is really, really important. Obviously, I spent years working in HIV, and it was always said that in countries where there was a lot of stigma around HIV, just saying it's healthcare, it's healthcare, it's healthcare helped a lot. And it did help a lot in contexts that were very hostile. So, complicated context is really important. I think that one of the biggest questions, and it's maybe the final question to you, because we can talk about it for a few minutes, is was there ever a moment where you felt hopeless doing sexual and reproductive justice work? And part two, if so, how did you find your way back to hope? In other words, how do you keep going? How do we make sense of this moment where we're seeing a total loss of previously achieved gains and rights? We have a lot of young people watching, I think. So have you felt hopeless? And then how do you find your way back?
You know, when I was in Yemen, I think that was like the most challenging physically and emotionally time of my professional life. But I didn't feel hopeless at all. I really, really didn't. I mean, I think I want to share I want to share something I learned from Yemen, which is not, which I learned from my Yemeni colleagues there, right? Because they are working under these, okay, so imagine all the things that we had to go through when the 5th of November, in the past week. That doesn't feel great, right? All of us know. But
No.
it doesn't feel great. But imagine living in Yemen as a woman, as a female doctor or a midwife or a nurse, working in a maternity hospital where since 2016 you've been in a civil war, right? And those women that I worked with in that hospital, every day I'd go to work and they would turn up and they give everything they could to the women that they served. Right. So, and I was really thinking about this, like, how do you do this? It's been 8 years. Well, when I was there, it was 6 years. You know, one of my colleagues, she hadn't seen her, she sees her son like once a year or something because her son lives across the front line. And even though it should be like a 20-minute car journey, it takes 3 hours because she needs to go like this in order to avoid the front line. And I was just thinking, like, under these conditions, these relentless conditions, how do you maintain hope? And for me, I think the answer was really, I mean, first of all, it was in their faith. And I'm not religious at all, but I learned a lot about faith when I was there, and they pray 5 times a day. And you never notice them like going off to pray or whatever, right? But like they do. And when I look at how that gave them strength, it takes them in their busy day. And I contrast this to my Muslim colleagues working in the NHS, where it's just like you don't have time to go to the toilet. You're just like working, without a break, without lunch, and they just prioritize that amount of self-care, that 3 minutes of self-care, 5 times a day. They go and they sit and they have that period of peace to give them a little bit of self-care. I think that keeps them going. And the other thing that keeps them going is the sense of community. So when I was there in Ramadan, which is when you fast, right? They would always prioritize breaking their fast. So it was so important for them at the end of when the sun goes down, no matter how busy it is, they carve out that time to sit together and have a meal together and break their fast together. So that sense of community and these women giving strength to other women really, taught me a lot about how the relativity of what feeling hopeless actually means. And they didn't feel hopeless. So people ask me like what was it like, what did they talk about, what did they think of the Houthis and blah blah blah, and I was just like, we don't talk about politics. We talk about like recipes, and we talk about our kids, and we talk about like makeup. We don't, or like how to do your hair, like it's just like women talk about normal things when you're in the company of other women, and that's what daily life is like. It's not about like the next political thing that's going to happen, right? So I think that's what I learned. You know, it's about support, it's about like maintaining a sense of self and a sense of community, and just finding joy in everyday things and everyday pleasures, because you know, things aren't going to change overnight, you know.
Yeah, I think that's a great answer. And I would just add that I think, you know, all over the world, there are just amazing people stashed all over, providers, you know, people who are making sure that in places where it's illegal, that people need abortions can get them. I mean, I feel like we're hearing a lot about in the USA right now that people are hiding, they're self-censoring. You just need to go into the banned states and look, or even not the banned states, and look at the incredible network that has been created, a network of care for the women and pregnant people being hurt. And you realize that, you know, there's hope everywhere, because there are so many good people who are so committed to these issues. So we're almost at the end. Um, and we have a couple more questions, and then we'll call it the end. But I think that question was quite important because we don't want anybody losing hope. I think that there's plenty of reason to hope and there's plenty of reason to fight. Okay, Dr. Das, now that you've dug in, researched, and reflected in your time as a fellow, what do you plan to do next with your learning, thinking about bodily autonomy? Any priorities for your own next steps?
So this is I don't know whether like planted that question, but it's a great opportunity to tell everybody about my project.
Great.
I'm whilst here, I'm doing an oral history project, and I'm calling it the Post-Ops Abortion Access Oral History Project. And I'm basically collecting the oral histories of lots of different people who have been activists, who have been advocates, who have been providers, directors, organizational leaders, basically giving me a chance to talk to all this breadth of really interesting people. And I'm doing recordings as part of this oral history, and the SRJ Hub, we're going to turn the oral histories into some kind of learning that we can disseminate. So I'm in conversation with our media team about what we can do in terms of using the audio and bringing those stories to life. So all these stories that I'm hearing, to enable all of you to have a chance to hear snippets of the wisdom that I'm collecting as well. Yeah, and well, who knows what else lies ahead.
Well, I know we all know that whatever it is, it will be very, very important. I think, you know, there's just one last question. And before I forget, I really want to thank Shayanda Noha, who's been who organized this. She's our SRJ Hub manager, and everybody involved with the SRJ Hub, big thank you. So what organizations are you seeing working on reproductive justice in the US that you think are doing innovative work or approaches? I think you mentioned some of them, but I don't know if you want to say a couple more words and then we'll close out.
Yeah, I mean, I suppose, well, when I start releasing the oral histories, you know, the excerpts, you can see comprehensively who I've been talking to. I've been talking to uh you know, shield law providers like Aid Access, education organizations like RAP. Who else have I spoken to? Physician advocates, so PRH, Physicians for Reproductive Health. And I think they've got a medical students arm as well for the students amongst you. You can look that up. They do amazing advocacy training for physicians. Yeah, I mean.
Okay. Well, I know that, I don't know, I can't see everybody who's online, but I know that I'm speaking on behalf of many and saying thank you so much for, sharing this talk with us. And thank you so much for all of your work and, really being quite an inspiring, figure yourself. So we're thrilled that we've gotten to spend this time with you and we still have time left. So, I encourage everybody on this platform to be in touch with the SRJ Hub, follow us, send us your thoughts, and I'm sure Dr. Das would also be happy to hear from many of you. Thank you so much, and I look forward to working together through this incredibly complicated moment in history. So thank you, Dr. Das. Thank you, everyone, and we'll see you soon.
Bye, Terry. Thank you.
Bye.